Excellent. And can you see that?
Yeah, we can see that.
Great. So I'm Jamie. I'm a doctor currently working on the respiratory ward at St George's Hospital. And today I'll be giving you a lecture on liver bloods interpretation. So how to interpret any liver function tests that you send in the hospital. There'll be 9 SVAs throughout the PowerPoint, and after each one I'll explain why the answer was correct, and I'll give kind of an overview of that specific part of the liver blood interpretation. So what we'll do to begin with, we'll just go straight into the questions. This is just a bit of stuff about Quesmed and the Quesmed app. So question number 1. A 31-year-old man with no past medical history presents to the GP practice with a history of feeling generally unwell. He reports a recent illness with fevers, myalgia, and fatigue. He reports that his skin became more yellow during this illness. He had no abdominal pain and the fevers have now settled. He works in an office and has no recent travel history. On examination, you notice sclera icterus, but nothing else to note. And blood results are attached on the screen there. So looking at these blood results, what is the most likely diagnosis? I think Millie's going to send a poll.
So another 10 seconds.
Okay. Excellent. So most people went for B, 38% of people went for B. A few people thought C, a few people thought A, and then a couple of people thought D and E. But B was the most chosen, and B was the answer. So this is a young man who has kind of a very brief self-limiting illness, and then he became jaundiced during his illness. And if you look at his blood results, you can see that he's got a raised bilirubin, which we already know because we know he's jaundiced. And if you look below the bilirubin, you've got an unconjugated bilirubin, which is also raised. Usually you would expect your unconjugated bilirubin to be less than half of your total bilirubin. So if someone has an unconjugated bilirubin, that suggests that the problem is before the bilirubin is conjugated, and the bilirubin is conjugated in the liver. So it's either a problem with conjugating the bilirubin itself or a problem before it gets to the liver. Gilbert's is basically a mutation in the enzyme that conjugates bilirubin. And Gilbert's causes a self-limiting jaundice when someone either does exercise or becomes acutely unwell or becomes malnourished for some other reason. And so it sounds like this man had a short viral illness, maybe the flu, and then became jaundiced because of this viral illness. And that's how Gilbert's presents. The reason it's not acute cholecystitis is because he has no abdominal pain, and his ALT and his ALP are both normal. And it's an unconjugated bilirubin. Whereas with acute cholecystitis, you'd tend to see more of a conjugated bilirubin, and he would have abdominal pain. With hepatitis A, you would tend to see, again, a conjugated bilirubin being raised, and you would see ALT being raised as well with the hepatic injury. The reason it's not acute or autoimmune hemolytic anemia is that the reticulocyte count is normal. And with the hemolytic anemia, you would expect the reticulocyte count to be raised. And with that, the MCV would be raised because reticulocytes are slightly larger cells than red cells. So that would increase your MCV. And it's not alcoholic hepatitis because this would also cause the ALT to be raised. So when we're thinking about liver function tests, and especially bilirubin, it's important to think about how bilirubin is metabolized. And this helps us to interpret any, this helps us to think of an approach to interpreting a high bilirubin. So if we look at our red cell, we've got hemoglobin, which is converted into heme and globin. The heme is converted into biliverdin, and then that's converted into unconjugated bilirubin, which is bound to albumin in the plasma. That's taken to the liver, where the bilirubin is conjugated with this enzyme here, UGT1A1, and that's the one that has the mutation in Gilbert syndrome. The bilirubin is conjugated in the liver to get conjugated bilirubin. This conjugated bilirubin then goes through the biliary system, so through our bile ducts, and into our small intestine via the ampulla. And then the conjugated bilirubin in the small intestine gets converted into something called urobilinogen. And then about 50% of the urobilinogen is converted into stercobilin. And stercobilin is what makes our stool dark. And that gets passed in the feces. The other 50% of urobilinogen gets filtered out into the portal vein and then back into the systemic circulation. And then it gets filtered out by the kidneys. So urobilinogen gets converted to urobilin, which gets excreted by the kidneys. And that gives, so that's kind of the bilirubin metabolism and how we can interpret bilirubin results. So if we look at bilirubin, we can split it into unconjugated and conjugated bilirubin. So if you have an unconjugated bilirubinemia, hyperbilirubinemia, it means that you've either got prehepatic jaundice or prehepatic cause of the high bilirubin. So that could be a hemolytic anemia, so the red cells being hemolyzed, or it could be due to impaired conjugation, so Gilbert syndrome. Whereas if you have a conjugated hyperbilirubinemia, it implies that there's dysfunction, there's hepatocellular dysfunction, so the hepatocytes are bursting open and releasing the conjugated bilirubin, or there's impaired hepatic excretion, so a post-hepatic cause for jaundice. So that implies that there's something blocking the conjugated bilirubin from getting into the small intestine, so a gallstone, for example. And we can also look at this in the urine using urinalysis. So unconjugated bilirubin is not water soluble, whereas conjugated bilirubin is water soluble. So this is important because we can use urinalysis to help us determine whether we have a conjugated or an unconjugated bilirubinemia. So if we look at a normal patient, for example, we wouldn't expect to see any bilirubin in the urine, but we do see urobilinogen in the urine, and that's a normal patient. If you have prehepatic disease, because you're not able to conjugate your bilirubin, we still wouldn't see it. You only have unconjugated bilirubin, and unconjugated bilirubin is not water soluble, so can't get into the urine. So with prehepatic cause of a high bilirubin, you won't have any bilirubin in the urine, but you'll have an increased urobilinogen in the urine. If you have a hepatic cause of high bilirubin, you would expect to see bilirubin, conjugated bilirubin, leak from your liver, and then that can appear in the urine. So you can see that on the urine dip, a high bilirubin. And that's the case for hepatic and post-hepatic disease. If you look at the urobilinogen in hepatic disease, it's increased. And then in post-hepatic disease, the urobilinogen is absent or decreased in the urine. And this is because your conjugated bilirubin can't get into your small intestine because it's blocked. And if your conjugated bilirubin can't get into your small intestine, then it means you can't make any urobilinogen, which means you can't make any stercobilin. So that means with post-hepatic disease, where you have a blockage between the liver and the small intestine, so a gallstone, you see no urobilinogen, no stercobilin, which means you have pale stool, but you have lots and lots of bilirubin getting into the conjugated bilirubin, which is water soluble, getting into the kidney, being excreted in the urine, and then you get dark urine. So if someone's got high bilirubin, dark urine, pale stool, then you know they've got some sort of obstructive disease here. So something obstructing the biliary tree. So that's bilirubin metabolism. So question 2, a 40-year-old woman with a high BMI but no other past medical history presents to the emergency department with a 1-day history of abdominal pain in the right upper quadrant and fevers with rigors. She reports pale stools. On examination, she has tenderness in the right upper quadrant and a yellow tinge to her skin. Her blood results are attached. Urinalysis shows bilirubin present and urobilinogen absent. Which of the following is the next best investigation? And her blood results are attached on the right there.
Another 10 seconds.
Excellent. So most people thought it was B, and that is the correct answer. So this is a typical presentation of ascending cholangitis. It has all of Charcot's triad of fever with rigors, right upper quadrant pain, and jaundice. And we already discussed from the previous slide that she has pale stools, and so that implies that she has some sort of obstructive disease. And you can tell from the high bilirubin and the deranged ALT and ALP that she's got an obstructive disease because she's got such a high ALP. The ALP is much, much higher than the ALT. And in any patients with obstructive disease, the first investigation that you would do is an abdominal ultrasound, because abdominal ultrasound is cheap, it's easy, it's quick, and it can show whether there's any biliary duct dilatation. And it can also visualize gallstones to see if there are any gallstones there. If you thought she had obstructive disease due to a malignancy, for example, a pancreatic cancer, then you might consider a CT abdomen pelvis. But MRCP and ERCP tend to be investigations that we do following the abdominal ultrasound. So when it comes to thinking about liver function tests, most people call them the ALT and ALP liver function tests, but they actually don't measure the synthetic function of the liver. They're actually just plasma enzymes that indicate hepatic or biliary pathology. So ALT are enzymes that are abundant in hepatocytes, and when hepatocytes are damaged, they burst open and release the ALT. And ALP is an enzyme that is synthesized in the biocanaliculi cells, and cholestasis causes an increase in the synthesis of ALP. It's important to remember that ALT can also be found in the muscle, And ALP can also be found in the bone and in the gut and in the placenta. And gamma GT, or gamma glutamyltransferase, is another blood test that we use in liver function. And it tends to be elevated in hepatobiliary disease, but not in bone disease, for example. So gamma GT is a bit more specific to the liver, and we use it when we see an elevated ALP and we're not sure whether the ALP is elevated due to a liver disease, so an obstructive liver disease, or bone disease, for example. So we would send it to gamma GT, and if the gamma GT is also raised, it implies that there's hepatobiliary pathology as opposed to some sort of other pathology. Often the ALT and the ALP are elevated in most causes of liver disease, but one of them tends to predominate. So if the ALT predominates, it implies that there's a hepatic cause. So there's hepatocellular damage, which is causing the liver disease. Whereas if the ALP predominates, it usually implies there's a post-hepatic cause or an obstructive cause. So something in the biliary tree that's obstructing the flow of bilirubin out of the liver. And so these are really important. This is a really important thing to remember when we're thinking about the ALT and the ALP. It's also important to remember that ALP, the upper limit of normal, is much higher than for ALT. And we base it on the upper limit of normal for that test, not on which is higher, the ALP or the ALT. It's based on how much higher than the upper limit of normal it is. So the upper limit of normal for ALT is about 40. So if the ALT is 120, then it's 3 times the upper limit of normal. Whereas the upper limit of normal for ALP is around 130. So ALP could be 120 as well, but the ALP would be normal, and that would be the ALT would be very elevated, which would imply an intrahepatic cause. So that's an important thing to remember. Yeah, as I say, one often predominates. And I'm going to repeat it again, it's just an important thing to remember that ALT and ALP don't reflect the synthetic function of the liver, but we'll talk about the synthetic function of the liver shortly. When we have any cause of liver disease, a very easy imaging test to get and cheap imaging test to get initially is an abdominal ultrasound. And that can demonstrate quite a few different things. You can see bile duct dilatation. So if there is obstruction due to a gallstone, you would see dilatation of the bile ducts. It can show you any pancreatic masses, which could be obstructing the biliary tree. It can show you any tumours in the liver, like a hemangioma, for example. It can show you evidence of cirrhosis in the liver, and it can also show you hepatomegaly, so if you have an enlarged liver. So it's quite an easy investigation to request. It's kind of no risk to the patient, no risk of radiation to the patient. So that's why that was the first investigation you would request in that question. So question 3, a 65-year-old man is brought to the emergency department by ambulance after being found lying in the street with a reduced conscious level. You are unable to obtain any further history from the patient. On examination, he has jaundice with a distended abdomen and right upper quadrant tenderness. He appears unkempt and his GCS is 12. Blood results are attached. Which of the following is the most likely diagnosis based on these blood results on the screen?
Another 10 seconds.
Yeah, so D is the answer. So most of you got, 76% of you chose alcoholic hepatitis. So that's the correct answer. So this is a man with who's got a reduced conscious level, which could be from alcohol intoxication or it could be from hepatic encephalopathy. He's jaundiced and he's got abdominal distension, which could be ascites due to liver failure. And this is obviously an acute thing that's happened. If you look at his blood tests, you can see that he's got the high bilirubin. You can see that he's got an elevated ALT and a normal ALP. So that implies intrahepatic damage instead of posthepatic damage. And he's got a raised gamma GT, which implies that these investigations, that it's a hepatobiliary cause, and a slightly elevated CRP as well. But the main thing here is that the AST, which is another plasma enzyme that we use in liver function tests, is significantly elevated, and it's elevated much more than the ALT. And when that happens, it often implies that the cause of hepatitis is alcohol. So AST is, or aspartate transaminase, is also released in hepatocellular injury like ALT. But AST is also found in skeletal muscle, it's found in red blood cells, and it's found in the myocardial cells. ALT is slightly more specific for hepatocellular injury than the AST. So we usually just use ALT if you send it off to any normal lab, it will just send you back an ALT. But you can request AST sometime. You can request AST as well if you wanted to, but that's usually a separate request. And as was the case in this question, when the AST to ALT ratio is more than 2:1, that tends to imply that the liver disease is due to alcohol. So that tends to imply alcoholic liver disease. It's also important to remember to consider other causes of an elevated AST, such as rhabdomyolysis or myositis, because it can be, as I said before, it can be released from the muscle. Another thing that I wanted to mention on this slide was just to think about if the ALT is acutely abnormal, the ALT can get really, really high in some cases. So when the ALT is above 1,000, if you ever see that in clinical practice, that tends to be due to one of three reasons. So it's either acute ischemic hepatitis. So if someone has significant septic shock, they often get an acute ischemic hepatitis following that. Acute viral hepatitis and toxins, so paracetamol. So these are the main three things that cause an acute rise in your ALT above 1,000. So question 4, a 45-year-old woman has been brought to the emergency department by her partner due to reduced conscious level. Her partner reports that she had been out for most of the day, and when she returned, she was confused and drowsy. She has a history of depression and fibromyalgia. On examination, she is jaundiced with right upper quadrant tenderness. Her GCS is 11 and she is afebrile. Blood results are attached. Which of the following is the next best investigation in this patient based on these blood results?
Another 10 seconds.
Great, so most people went for E, some people went for C and B. So the correct answer for this one is E. So this is a lady who's presented with acute liver failure. She's got a reduced GCS, she's jaundiced, she's got right quadrant tenderness, and she's got a high bilirubin. She's clearly got a high ALT and AST with a fairly normal ALP. So this is a hepatic cause. So this is something causing an acute hepatocellular injury. And the prothrombin time is elevated with a fairly normal APTT, and the ammonia is also elevated. So these are all things that indicate that she's got acute liver failure. So we have to look for what's caused her acute liver failure. Salicylates don't tend to cause liver failure, so there's no point in doing a salicylate level. Liver ultrasound is a reasonable thing to request, but wouldn't be the first thing you would request, because the most likely cause of this lady's liver failure is going to be paracetamol overdose. Given the history that she's been out for most of the day, she's got depression and fibromyalgia. So that all kind of points you a bit more towards paracetamol overdose. You would send a viral hepatitis screen as well, but that, again, isn't the most pertinent investigation in this patient. And if you have an elevated paracetamol level in this patient, usually it's important to remember that we use the normogram to decide whether to give IV NAC in paracetamol overdose. But if we don't know when the paracetamol was taken, or we don't know if it's a staggered overdose, if we have a high suspicion, then we would just treat anyway without using the normogram. But it's still important to do a serum paracetamol level in this patient, just to see if you can find the cause of her acute liver failure. And that's the most likely cause at the moment. So in terms of acute liver failure, you can have acute liver failure, or you can have acute on chronic liver failure. So acute liver failure happens in a healthy liver. Acute on chronic happens in a patient with chronic liver disease and is more common than acute liver failure. When we think about acute liver failure and what happens, it's important to think about the functions of the liver, because if you know the functions of the liver, then you'll know what happens when the liver fails. So in terms of the liver's functions, in terms of metabolic functions, it does gluconeogenesis. So it mobilizes lactate to do gluconeogenesis, and it also does glycogen metabolism. In terms of synthetic function, it synthesizes albumin, it synthesizes thrombopoietin, which leads to platelet synthesis, and it synthesizes vitamin K dependent clotting factors, which are important in the prothrombin time. It's also works in terms of excretion and detoxification, so it excretes drugs and toxins, and it excretes ammonia from amino acid metabolism. And then, as we talked about a few slides ago, it does bilirubin conjugation and excretion. So if we think about what goes wrong with, so if you have liver failure, you have a failure of all of these functions, basically. So from a metabolic point of view, you have increased risk of hypoglycemia, and you often see a high lactate. So anyone with acute liver failure will have a high lactate, and it's an important cause of high lactate to remember. You'll see an increased prothrombin time or an increased INR. You'll see you'll see a reduced albumin, and that reduces your oncotic pressure in your plasma. So you'll get fluid leak from the plasma and ascites. And because of the reduced thrombopoietin, you get a thrombocytopenia, so you get low platelets. You can get buildup of drugs that are excreted by the liver, and you can also get a high ammonia, and that's what causes your hepatic and that then results in an encephalopathy, and that's called hepatic encephalopathy. And as we've spoken about already, you can get a high bilirubin. And your prothrombin time is your earliest indicator of synthetic function. So it's important to anyone who you suspect of having acute liver failure, it's important to send an INR to look for their synthetic function. And in terms of management of paracetamol overdose and when to refer a patient for liver transplant, there are King's College Hospital criteria for liver transplant. And there are criteria for liver transplant in paracetamol overdose and in acute liver failure for another cause. So, and these are the indications for acute liver transplant in paracetamol overdose. So either a pH of less than 7.3, or all of a PT, a prothrombin time above 100 seconds, a creatinine above 300, or grade 3 or 4 encephalopathy. So question 5, 52-year-old man presents to the GP practice for follow-up of abnormal blood tests. He has a history of intravenous drug use, but no other past medical history. Initial blood tests are attached. Which of the following is the most likely mechanism of these laboratory findings? So you've got quite a lot of investigations to read through there on the right of the screen.
Another 10 seconds.
Yeah, so quite a mixed response there, but most people thought C, and that's the correct answer. So this is a patient who has a slightly abnormal AST, a normal ALT, an abnormal bilirubin, and a normal ALP. So it implies that there's a tiny bit of hepatocellular damage there. And if we look at the hepatitis B serology and the antigens and the antibodies, we can see that the hepatitis B surface antigen is positive. So if the surface antigen is positive, it means that infection is present. So and that could be acute infection or chronic infection. So we know that surface antigen positive, that means infection is present. The anti-hepatitis B surface, so the surface antibody is negative, which means infection hasn't been cleared. And if we go down to the hepatitis core antigen, so the IgM is negative and the IgG is positive. So the IgM is negative, that means it's not an acute infection. If the IgM is positive, that's an acute infection. So IgM is negative and IgG is positive, which means it's a chronic infection. And then if we look at the hepatitis B E antigen, the E antigen is basically a marker of viral load or infectivity. And if your E antigen is positive, it means you have a high viral load and you're a high infectivity. But if your E antibody is positive and your E antigen is negative, then you have a low viral load and a low infectivity. And those are summarized in this table here. So when we're screening for viral hepatitis, we usually screen for A, B, and C. For A, we send IgM and IgG. For hepatitis C, we can send hepatitis C antibodies. We can also send RNA for PCR. And then for hepatitis B, we do this array of tests, which is important to learn for your exams. And so we'll just go through each one and what happens to each of the antibodies and antigens. So in acute infection, as I said before, your surface antigen is positive. Usually in acute infection, your E antigen will also be positive, and your IgM will be positive because IgM is the much more acute phase than IgG. If you have a resolved infection, then you'll have all of your antibodies and no antigen because you've had the infection, you've been exposed to the antigens, so you've got antibodies to everything and you've got no antigen left. Whereas if you've got a chronic infection, then you've still got your surface antigen. As I said, if surface antigen is present, then infection is present. So chronic infection, with a high viral load, you've got your surface antigen. You've got your E antigen because it's a high viral load, so the E antigen is present. And then you've got an IgG for the core antibody, not an IgM because it's a chronic infection. And then if you look at the chronic infection with a low viral load, you've got your surface antigen again. You've got your E antibody, not the E antigen. And then you've got your IgG for the core antibody. And in vaccinated people, because we vaccinate with the surface antigen, then you only have antibodies to the surface antigen. So you don't have any other antibodies when you're vaccinated. So if someone only has the hepatitis B surface antibody, then you know they've previously been vaccinated instead of previously been infected. So question 6, a 55-year-old man presents to the GP with a 3-month history of worsening joint pain, fatigue, abdominal pain, and 3 kilograms of weight loss. He has a history of type 2 diabetes mellitus, diagnosed 10 years ago. On examination, he has swelling of the small joints of both hands, some patches of increased pigmentation on his skin, and hepatomegaly. His blood tests are attached. Given the most likely diagnosis, which of the following is the next best investigation? So you've got some blood results there to look at on the right side of the screen.
Another 10 seconds.
So mixed response there. So the correct answer for that one is serum ferritin. So this is quite a difficult one. This is a case basically of a middle-aged man. It's a chronic history, and he's got evidence of liver disease. So he's got chronic liver disease with raised bilirubin, ALT, and AST. So he's got chronic liver disease. He's got a history of diabetes, and he's got kind of quite non-specific symptoms of joint pain, fatigue, and he's clearly got hepatomegaly. The most important things to note from this question are the history of diabetes, the increased pigmentation on his skin, and the chronic liver disease. And that all points towards a diagnosis of hereditary hemochromatosis. Now, we're getting into the kind of rare causes of liver disease now, but it's important to remember all of these as causes of liver function derangement. And hereditary hemochromatosis is one of them. And one of the first investigations you would do in that is serum ferritin as a kind of a screening investigation. Serum ferritin is usually elevated in hereditary hemochromatosis. Alpha-1 antitrypsin level, alpha-1 antitrypsin deficiency is another cause of chronic liver disease, again, quite rare. Serum ceruloplasmin and 24-hour urine collection for copper are both used to look for Wilson's disease, another cause of chronic liver disease. And liver biopsy is kind of our last resort investigation if we've got chronic liver disease and we don't know the cause. A liver biopsy would be considered. So in terms of a couple of the kind of genetic causes, which are or rarer causes of hepatic disease or chronic liver disease, the three main ones we talk about are hereditary hemochromatosis, Wilson's disease, and alpha-1 antitrypsin deficiency. So hereditary hemochromatosis is caused by a mutation in the HFE gene, and that results in iron deposition, increased iron uptake, and iron deposition in various parts of the body. The main ones being the liver, the skin, endocrine organs, and the myocardium. So the endocrine organs include the pancreas and can include the gonads as well. So you often see some degree of hypogonadism, and you often see diabetes because of iron deposition in the pancreas. Iron deposition in the skin causes this kind of bronzing of the skin. So often it's called bronze diabetes. So if you ever see those three things in a question, skin pigmentation or bronze skin, diabetes, and liver impairment, it's important to think about whether it could be hereditary hemochromatosis. And it can also cause iron deposition in the joints, which is why you get joint pain. And in the blood tests, the initial investigations you would do are a ferritin and a transferrin saturation, both of which would be elevated. Wilson's disease is another genetic cause of chronic liver disease, which causes increased copper deposition in the liver, the brain, and the eyes. And when you get increased, it usually goes in the basal ganglia, so you get Parkinsonian symptoms, and you can get psychiatric abnormalities as well with that. In the eyes, you see the Kaiser-Fleischer rings. And for that one, you do ceruloplasmin, which is low, and you can do a 24-hour urine copper collection, and you would see a high urinary copper level. And then the third genetic cause of hepatic disease, again quite rare, is alpha-1 antitrypsin deficiency, which basically causes emphysema and causes cirrhosis. And so if you see someone who has a combination of emphysema and cirrhosis, then alpha-1 antitrypsin deficiency is a potential cause. Question 7. A 34-year-old lady presents to the GP with a 4-month history of worsening pruritus and lethargy. She has a past medical history of rheumatoid arthritis and autoimmune hypothyroidism. She takes methotrexate and levothyroxine. On examination, she has scleral icterus, but no other findings. Blood tests are attached to the right of the screen. Based on these blood tests, which of the following is the most likely to be positive in this patient?
Another 10 seconds.
So another kind of varied response. This is also quite a difficult question. So the correct answer here is antimitochondrial antibodies. So this is a patient with, again, a chronic history of, she's got pruritus and lethargy, and an autoimmune history. And you can see she's got sclerotic icterus. So she's got jaundice and she's got the history of pruritus. And from her blood test, you can see she's got the high bilirubin, and she's got a high ALP. So she's got some obstructive liver disease. So she's got a chronic cause of obstructive liver disease and an autoimmune history. And the other thing to note in the question is that she's got an elevated IgM, whilst the other immunoglobulins are normal. So all of these different things point towards primary biliary cholangitis, or PBC. So there are a couple of causes of autoimmune liver disease. Primary biliary cholangitis is one of them. And in PBC, we often see elevated or the presence of antimitochondrial antibodies, most specific to, and they're kind of seen in more than 90% of people with PBC or primary biliary cholangitis, which this case fits with most. If we look at the different causes of autoimmune liver disease, there's primary biliary cholangitis, primary sclerosing cholangitis, and autoimmune hepatitis, which are the three main ones that are all causes of chronic liver disease. So primary biliary cholangitis causes scarring and granulomatous inflammation of the intrahepatic bile duct. And due to that, it causes a rise in ALP because it causes obstruction. And it can present with jaundice, fatigue, and often presents with pruritus or itching. And it's associated with autoimmune things like rheumatoid arthritis, thyroid disease, etc. And as I said, you see antimitochondrial antibodies in more than 90% of these patients. And you often see a raised IgM. So that's an important thing to look out for in patients with chronic liver disease. Primary sclerosing cholangitis causes inflammation, fibrosis, and strictures in the intra and extrahepatic bile ducts. So you often see this kind of stricturing pattern on imaging. And that can also present with similarly with jaundice, pruritus, and sometimes abdominal pain. And the primary sclerosing cholangitis is often associated with an ulcerative colitis. And in primary sclerosing cholangitis, you can see lots of different antibodies positive. So you can see p-ANCA positivity or ANA positivity. And in autoimmune hepatitis is an autoimmune inflammation and destruction of hepatocytes. So you see a rise in ALT more so than in ALP. And that again causes quite constitutional symptoms like fatigue, loss of appetite, but can also cause jaundice and hepatomegaly as well. And that's associated with autoimmune conditions as well, like autoimmune thyroiditis, villous anemia. And in autoimmune hepatitis, about 80% of those patients will have a positive smooth muscle antibody. And they tend to have a raised IgG. So that's an important immunoglobulin to look for in those patients. So those are kind of your main autoimmune causes of chronic liver disease and the antibodies that are positive in them. So question 8, a 65-year-old lady presents to the GP with a 2-month history of lethargy, reduced appetite and weight loss. She has no abdominal pain, fevers or night sweats. She's got a past medical history of hypertension, rheumatoid arthritis and breast cancer, treated with a wide local excision 5 years ago. On examination, she has hepatomegaly but no other findings, and blood tests are attached on the right of the screen. So based on these blood results, which of the following is the most likely diagnosis?
Another 10 seconds.
So A and E, the most common options there. So the answer to this question is A, liver metastases. So this is a lady who's presented with lethargy, reduced appetite and weight loss is obviously a red flag feature. She's got no abdominal pain, which makes gallstone disease very unlikely. She's got no fevers, no night sweats. She's got a history of breast cancer. So recurrence, it's always important to think about recurrence. And on examination, she's got hepatomegaly, and then she's got raised ALT, raised AST, and a raised ALP. We know it's not alcoholic hepatitis because we would see a much higher AST. So the options left are cholangiocarcinoma, hepatocellular carcinoma, and liver metastases. The AFP is normal, and AFP is a good tumour marker for hepatocellular carcinoma. And that's one way that we can rule out hepatocellular carcinoma as what's going on here. The ALT and the ALP are both raised, and neither of them really predominate. So this is kind of a mixed picture, mixed hepatic / obstructive picture. When we see this mixed picture, it's important to think about liver metastases as a cause. And in terms of malignancies, liver metastases are much more common than primary hepatocellular carcinoma. In cholangiocarcinoma, you would tend to see a much greater ALP because it tends to cause more of an obstructive picture than the raised ALT and AST. And that's why the answer here is liver metastases. So in terms of thinking about abnormal ALT and ALP, as I said, most causes of liver disease cause both to be abnormal, but one tends to predominate, so you often have a much higher ALT or a much higher ALP. But when neither predominates and you have a mixed picture, a couple of causes of that could be liver metastases, as we've previously mentioned. Hepatocellular carcinoma can cause both to be elevated, and that's where we can send that alpha-fetoprotein as a tumour marker. And drugs are quite a major cause of derangement of ALT and ALP together. And there's a list of drugs there that can cause liver function derangement. Coamoxiclav being a very important one to remember in a hospital because so many patients are prescribed coamoxiclav in the hospital. And it's important to think about when our ALT or our ALP is elevated, it's important to think about other causes that aren't to do with the liver. So as I said at the start of the lecture, it's not only the liver that can cause our ALP or our ALT to go off. So if the ALP is elevated by itself with a normal gamma GT, it's important to think about bony disease. So bony metastases, bone tumours, any recent fractures or vitamin D deficiency, for example. And when our ALT or our AST are elevated by themselves with a normal ALP, normal bilirubin, normal liver basically, it's important to think about things like rhabdomyolysis, like we spoke about before, where you often tend to see a much higher AST than ALT, or a myocardial infarction. Because as we said, AST and ALT can be present in the myocardial cells. Question 9. A 55-year-old man presents to the GP for a routine blood test. He is currently asymptomatic. He has a past medical history of type 2 diabetes, hypercholesterolemia, and is overweight. He drinks 1 bottle of wine each week. Examination is unremarkable, and his blood results are attached to the right there. Based on these blood results, which of the following is the most likely cause of which of the following is the most likely cause of these blood results?
Another 10 seconds.
Yeah, so most people thought that was B, and that's the correct answer. So this question is just a middle-aged man who's overweight, high cholesterol, type 2 diabetes. So he's kind of got all the risk factors for non-alcoholic fatty liver disease. And then on his blood test, he's got a slightly abnormal ALT and AST with a normal ALP. So this is, and he only drinks 1 bottle of wine each week, which is within the weekly recommendations, weekly limits for a man of his age. And this question is kind of just to emphasize that non-alcoholic fatty liver disease is the most common cause of liver derangement that we see in the community. And in terms of the other questions, alcoholic liver disease, he probably doesn't drink enough alcohol to have alcoholic liver disease. Chronic hepatitis C, he's got no risk factors for that. Drug-induced liver disease, the question mentions no drugs that could cause this. And it looks like it's kind of it's probably a more chronic picture. And autoimmune hepatitis, as we mentioned before, is quite rare. So the non-alcoholic fatty liver disease is much more likely to be causing acute liver derangement. So for the final slide, I'm just kind of trying to bring everything together as an approach to kind of deranged liver function tests. So you can kind of take this 4-step approach. So first of all, it's important to look at the ALT, the AST, and the ALP, and compare them to each other and compare them to the upper limit of normal, and see whether you think your patient has a hepatocellular, more of a hepatocellular, so an intrahepatic or an obstructive cause of their derangement. And you can consider a gamma GT to help you decide whether this is a hepatobiliary cause or another cause. And then look at the bilirubin, see if they've got a hyperbilirubinemia, and think about whether this could be unconjugated, whether this is unconjugated due to hemolysis or Gilbert syndrome, or whether it's conjugated, which is most other causes of liver disease. And remember, we can do the urinalysis thing, where conjugated bilirubin is water soluble and unconjugated is not. And then number 3, think about the liver's synthetic function. So is the synthetic function affected? So you can measure the albumin, you can look at the INR or prothrombin time, and you can look at things like glucose and lactate as well. And then number 4, find the cause. And in terms of finding the cause, you can think about it as an acute or a chronic, and then you can think about it as a hepatitis or an obstructive. So causes of acute hepatitis could be infection, ischemia, or toxins, or drugs. Causes of an acute obstructive picture, things like cholangitis, gallstone disease. Causes of chronic hepatitis, things like alcoholic liver disease, fatty liver disease, chronic infections like hepatitis B or C, genetic causes like hereditary hemochromatosis and Wilson's disease. And then in terms of chronic obstructive causes are things like our autoimmune causes like PBC and PSC, and pancreatic, things like pancreatic malignancies or cholangiocarcinoma. Often in the hospital, we send what's called a liver screen if someone has deranged liver function tests, persistently deranged liver function tests. And that includes basically everything that we've spoken about today. So it includes all of the viral serology, including EBV and CMV serology. It includes all of the antibodies that we talked about with our autoimmune causes, and the immunoglobulins that we talked about in the autoimmune causes of liver disease. It includes our ferritin, alpha-1 antitrypsin, and ceruloplasmin and urinary copper collection, all of which we talked about with the genetic causes of liver disease. And then we can also send a paracetamol and an alcohol level, especially for those patients presenting acutely with acute hepatitis. And as we mentioned toward the start of the lecture, a really easy non-invasive investigation is an ultrasound of the liver, which is what we often do first with patients with deranged LFTs. And you can also do a Doppler of the hepatic arteries and veins and the portal vein along with that to see if there's any kind of thrombosis there. And just as a note on the side here, in terms of deranged LFTs, the most common cause of deranged LFTs in the community tends to be non-alcoholic fatty liver disease. And the most common cause of newly deranged LFTs during a hospital admission, which is what you'll probably be seeing most commonly, it's often due to medications. So it's important to do a medication chart review to see if you can see any causes. And that's kind of a kind of general catch-all approach to deranged LFTs. So I think first of all, we'll go back to Millie, and then we'll see if there's any questions after that.
Thank you very much for that great session, Jamie. Just to say that the feedback form is on the website underneath where you're watching the video now, so we'd really appreciate if you could fill that out for us. Over to you again, Jamie.
Great, so now we'll take any questions. Shall we just go through them on here? So the first one, why do you get increased urobilinogen in prehepatic? So often prehepatic disease is due to hemolysis. So you'll get hemolysis, if we go back to the slide. So if we look at the slide, in terms of why do you get increased urobilinogen in prehepatic disease, if you follow the bilirubin, so if you get hemolysis, you get lots of release of unconjugated bilirubin in the plasma. So you get really high unconjugated bilirubin. and that gets conjugated in the liver, and then gets moved to the gut, where conjugated bilirubin is turned into urobilinogen, and then that gets filtered out into the portal vein. And it's just because you have such high concentrations of unconjugated bilirubin, and that all ends up kind of following through, meaning that the conjugated bilirubin, you get higher conjugated bilirubin, higher urobilinogen, and then that goes through to the kidney. And that's why you get increased urobilinogen in prehepatic. In case of increased unconjugated bilirubin or prehepatic jaundice, will it cause any changes in colour of stool or urine? So the next one is in the case of increased unconjugated bilirubin or prehepatic jaundice, will it cause any changes in colour of stool or urine? So in terms of prehepatic jaundice, you won't get a change in the colour of the urine because unconjugated bilirubin is not water soluble, so it isn't excreted by the kidneys. So the urine doesn't go dark because of the bilirubin, and it doesn't change the colour of the stool because you still get the conjugation and you still get urobilinogen and you still get the stercobilin in kind of hemolysis. And then the next question. Is it right to say that the investigation modalities is ultrasound, then MRCP, then ERCP in ascending cholangitis? Yeah, that is kind of the order of investigations that we would do. So we do an abdominal ultrasound to look to see if there's any evidence of bile duct dilatation. And if there is, you can do an MRCP to look at the biliary more accurately. It's just that MRCP is expensive. It takes a longer time to organise, and it's not as easy to do as an abdominal ultrasound, which is why abdominal ultrasound is the first investigation to do there. Why is it not A? I don't know which question that's referring to, but if you just ask another question on the thing, and then I can answer it directly. Does autoimmune causes also increase ALT above 1,000? Tends not to be above 1,000 with autoimmune causes. It tends to be much lower than that, actually. And then the next question: wouldn't ALT levels be in the thousands with paracetamol overdose? Often, yes, they can be, but they don't necessarily have to be for it to be a paracetamol overdose. So it can be much lower than that in a paracetamol overdose. It can be lower than that in a paracetamol overdose. So I've seen them with ALTs of 300, 400, 500 before. Although if it is in the thousands, as there's only kind of those three causes that I mentioned before: ischemic, toxins, or viral. And then the next one: would you not do VBG if you suspected paracetamol metabolic acidosis and then take paracetamol level at 4 hours? Again, because you don't know. And then the next question is the same. Would you not do VBG straight away with baseline bloods if you suspect paracetamol and then take paracetamol levels at 4 hours? You don't know when the patient had ingested the paracetamol. And that's why there's the that's why you would take paracetamol levels straight away instead of at 4 hours. Though usually, if you do know when the patient has taken the paracetamol, you would take the levels at 4 hours after ingestion. And why is it not C? Question 4. So why is it not C in question 4? Question 4 is this one, and it's not C because you wouldn't take serum salicylate levels for acute liver failure, because salicylates tend not to cause acute liver failure. The next one: why would someone who has been vaccinated against Hep B not be Hep B surface antigen positive in a hepatitis screen if we use surface antigen as the vaccination? Because you you don't use, basically because you make the antibody against the antigen, and then the antibody persists and the antigen doesn't persist. It's the same way as if you were infected with the surface antigen. Once you've cleared the surface antigen, you've got the antibody, but you don't have the antigen anymore. So it's just the same way as if you were infected with the surface antigen. That's why you don't have the surface antigen anymore after vaccination. And then, is there two types of autoimmune disease, like type 1 and type 2? There are a few different types of autoimmune hepatitis. And I didn't kind of go into them in the slide, but if you, so there are a few different types of autoimmune hepatitis that you can kind of go further into, and they're different. They all have very slightly different antibodies that tend to be positive. But the antibodies that were on the slide are the antibodies that you would look for first. So smooth muscle antibodies are the antibodies that you would look for first. And raised IgG is usually seen in most of the causes of autoimmune hepatitis. But yeah, there are about 3 different types of autoimmune hepatitis, all of which are fairly rare causes of chronic liver disease. Is it only hepatitis B that has all those tests? In terms of the surface antibodies, core antibodies, etc. Yes, it is only hepatitis B that has all those tests. What circumstances causes the viral load in a chronic patient to become high? That's a very good question, actually. It can be lots of different things. So if a patient is immunosuppressed, if a patient is elderly, if a patient has any other underlying medical conditions, if a patient is malnourished due to alcohol intake, those are kind of all the kind of reasons for the viral load in a chronic patient to become high. What was the diagnosis of pale stools and dark urine? So that's obstructive jaundice. So if there's something in the biliary tree blocking. If the prehepatic jaundice is not caused by hemolysis, but instead by decreased uptake by the liver, i.e. contrast or rifampicin toxicity, or decreased conjugation, i.e. Gilbert's, would you still get increased urobilinogen in urinalysis? No, you wouldn't, because you wouldn't be able to. You wouldn't be able to conjugate the bilirubin, so you wouldn't get increased urobilinogen there. It's more for if you have hemolysis that you would get increased urobilinogen. I think it was question 5. I assume you mean the one where it wasn't A. Question 5 wasn't A because if you have acute hepatitis B infection, then you would have a positive IgM. So your core antibody IgM would be positive in acute infection, and your IgG wouldn't necessarily be positive in acute infection. So if your IgM is positive, it implies much more of an acute infection. If your IgG is positive, it implies chronic infection or past infection. So if you took the hepatitis screen immediately after the vaccination, you might see the patient's surface antigen briefly. That's a good question, and I don't know the answer to that. Apologies. What might a slightly raised ALT but all other bloods normal indicate? If you are a carrier of hemochromatosis, would you have symptoms? So if you have a slightly raised ALT but all other bloods are normal, as I said in the slide, it could indicate the myocardial injury, or it could indicate rhabdomyolysis or another kind of cause of muscle injury. And if you're a carrier of hemochromatosis, would you have any symptoms? That is a good question, and I don't know the exact prevalence or incidence of kind of diabetes and complications in carriers of hemochromatosis. All I know is what happens when you have actually have the illness. So I'm sorry about that. What might I slightly raise? Oh, that was answered. 2 questions answered. Oh wait, not that, maybe 3. Sorry. Let me just have a quick look.